Imagine sneezing,
Yeah.
leaking a bit of urine, and being told by a doctor that your pelvic floor is just, weak and too loose.
Right, which happens all the time.
But in reality, your muscles are actually locked in a painful, suffocating spasm. Welcome to the deep dive.
Glad to be here.
Today, we are exploring a whole stack of medical journals, fMRI studies, and clinical physical therapy guidelines specifically for you.
Yeah.
Because our mission today is to answer a highly specific and, honestly, surprising question.
Yeah, it really is.
Can pelvic pain actually make symptoms of pelvic laxity, like looseness or organ prolapse, feel physically worse?
It's a critical question because pelvic floor dysfunction affects roughly 1 in 6 women.
Wow, 1 in 6.
Yeah. And the mechanism behind this proves that the pain and the exaggerated feelings of laxity are not just in your head. It is a measurable neurological rewiring of the brain and the body.
Okay, let's unpack this, because before we even touch the neurological side of things, we have to look at the physical mechanics of the pelvic floor. Because to understand how pain amplifies laxity, we first have to understand how a muscle being too tight can completely disguise itself as being, well, too loose.
Right. So to visualize the pelvic floor, think of a dynamic muscular hammock stretching from your pubic bone in the front to your tailbone in the back.
Okay.
It holds up your bladder, your rectum, and your reproductive organs. It controls continence, and it stabilizes your core. When things go wrong, we typically see 2 main dysfunctions. The first is hypotonicity.
Hypotonicity meaning the muscles are, like, weak, stretched out, lacking tone.
Exactly. This leads to things like pelvic organ prolapse. That's where the organs actually drop or bulge into the vaginal canal because the hammock is sagging.
Ouch.
Yeah, it comes with dragging sensations, heaviness, and stress, urinary incontinence.
Like if you sneeze and leak.
Right. That is the classic presentation of hypotonicity. But then we have the exact opposite problem, which is hypertonicity.
So a chronically tight, tense pelvic floor. The muscles are basically in a constant state of spasm.
Yes. And this leads to severe pelvic pain, pain with intimacy, and voiding difficulties, meaning it's hard to start a stream of urine or fully empty your bowels.
Let's put ourselves in the shoes of someone dealing with this. You're in chronic pain, you go to 5 different doctors, and you're sitting on the exam table.
Oh, it is so exhausting.
And the doctor does an ultrasound or an MRI, and they tell you that your imaging is totally normal. Nothing is torn, nothing is broken. The psychological exhaustion of fighting a ghost like that must just be overwhelming.
Yeah, absolutely.
But looking at the clinical data, the physical toll of that constant tension is staggering. Just a 10% increase in the resting tone of those pelvic floor muscles causes a massive 50% decrease in blood flow and oxygen to those tissues.
And think about what that means biologically. If you cut the oxygen supply to a muscle by half, the muscle can't clear out cellular waste.
So it just builds up.
Right. You get a massive buildup of lactic acid. It creates a deep burning soreness that, never goes away because the muscle literally never gets a break.
It's like holding a heavy bag of groceries halfway up to your chest for an entire week.
Yeah.
Of course your biceps are going to be burning and screaming. But wait, if a hypertonic muscle is tightly clenched and locked in a spasm, why do these patients often experience urinary leakage?
That's the big paradox.
Right, because leaking is the classic symptom of a weak, lax pelvic floor. If the muscular door is jammed shut from tension, how is anything getting out?
Well, to answer that, we have to look at how skeletal muscles actually produce power. For any muscle to exert force, like, squeezing shut to stop a sneeze from causing a leak, it needs to move through a full range of motion.
Okay.
It has to contract from a fully relaxed, lengthened baseline.
If I can use an analogy here, it's like a kitchen sponge.
I love the sponge analogy.
Right, so if the sponge is completely dry and relaxed on the counter, it could absorb a sudden spill. But if your hand is already squeezing that sponge as tightly as possible, and then a spill happens, the sponge can't absorb anything. It has no capacity left.
And because that sponge is already squeezed tight, any extra pressure just forces water right past it.
That makes so much sense.
A hypertonic pelvic floor is chronically exhausted because it's stuck in a partial, tense contraction all day. When you cough, jump, or sneeze, the muscle has 0 range of motion left to contract and protect against that sudden downward pressure.
So the result is leakage.
Exactly. To the patient, it feels exactly like laxity and weakness, but it is actually driven by pain, tension, and muscular exhaustion.
Tightness mimicking weakness.
Yep.
But an exhausted, burning muscle doesn't just sit quietly in the pelvis. It screams for help. And when that distress signal travels up the spinal cord, it hits a nervous system that is about to overreact.
And this is where the plot twists.
Right, because a lot of these patients had a UTI or a difficult childbirth or an endometriosis flare. The local tissue heals, the infection clears, but the pain and the tension stay. Why?
This is where we encounter central sensitization syndrome, or CSS. When pain persists beyond the normal tissue healing time, the nervous system itself fundamentally changes.
Okay.
You can think of CSS not as a broken part, but as a hypersensitive car alarm.
A car alarm that goes off just because a strong breeze blew past it.
Precisely. The alarm is real, the blaring noise is real, but the threat isn't. The spinal cord and the brain become hyperreactive.
Wow.
Your nervous system learns to treat completely normal sensations, like a full bladder, a light touch, or even just normal digestion of food as a massive tissue-damaging threat. It keeps your body locked in a protective pain cycle.
And this isn't just theory. We have this really cool fMRI study on provoked vestibulodynia, which is a chronic vulvar pain condition.
Yes, a very illuminating study.
Researchers put these women into an fMRI scanner to watch their brain activity in real time. But they didn't touch their pelvic area. They applied calibrated, moderately painful heat to the heel of their right thumb.
What's fascinating here is why they used the thumb. They wanted to prove that the pain processing issue wasn't just localized to the pelvis.
Oh, I see.
They were looking for a systemic physiological change in the central nervous system's circuitry.
And the results were wild. The women with this condition didn't just show altered brain connectivity during the painful heat stimulus on their thumb.
No, they didn't.
Their brains showed significant abnormal connectivity changes between the thalamus, the insula, and the amygdala, which are the emotion and sensory integration centers.
Right.
And this happened before the pain even started and lingered long after the pain ended.
Which tells us exactly how central sensitization operates. The brain is constantly anticipating the threat. It's ruminating on the possibility of pain.
It's just waiting for it.
Yeah, it creates a continuous, unbroken loop of pain modulation, even when no active damage is occurring. It is bracing for impact 24/7.
If you are listening to this and you've ever been told your chronic pain shouldn't exist because your scans are clear, this is your vindication. Your nervous system has fundamentally changed how it processes data. It's a biological reality.
And it is heavily influenced by how the physical tissues interact with those sensitized nerves.
Here's where it gets really interesting. Now that we understand central sensitization syndrome, the hypersensitive car alarm, we have to directly answer our core question.
Right.
How does this neurological state affect a structural issue? Specifically, pelvic organ prolapse, where the tissues actually are lax, stretched, and loose. How does pelvic pain make the physical symptoms of laxity feel worse?
Well, to understand this collision, we have to look at prolapse not just as an anatomical dropping of organs. When those organs drop even slightly, they put continuous mechanical strain on the surrounding ligaments and connective tissues.
So stretching those tissues like old rubber bands.
Exactly, pulling on all the nerve endings. And that chronic strain acts as a relentless trigger, continuously firing off nociceptive or pain signals to the spinal cord.
Oh, wow.
Over time, that constant firing leads straight to central sensitization. The nervous system gets overwhelmed by the barrage of data and arms that hypersensitive car alarm.
So the volume knob just gets stuck on high.
Oh, yes. Therefore, the feeling of heaviness, the sensation of a bulge, and the dragging pain associated with the laxity are neurologically magnified.
The structural prolapse might be mild. A doctor might look at it and say, well, this is barely a grade 1 prolapse.
That happens so often.
But because the brain is sensitized, the patient feels it as a massive, debilitating, heavy bowling ball dropping out of them.
Exactly. The brain is amplifying the physical reality of the laxity.
And we can't ignore the hormonal angle here, which acts like pouring gasoline on the fire. In postmenopausal women, dropping estrogen levels severely alter how the brain handles these pain signals.
This is a crucial piece of the puzzle. Estrogen isn't just a reproductive hormone.
Right.
It is deeply involved in the central nervous system. Specifically, estrogen helps regulate endogenous pain inhibitory mechanisms, basically your brain's natural painkillers.
Okay.
It impacts the GABAergic and NMDA receptors in the brain.
Wait, GABAergic receptors. For the listener who isn't a neurologist, are those essentially the brain's calming chemical gates?
That's a great way to put it. GABA is the primary inhibitory neurotransmitter in your brain. It tells neurons to calm down and stop firing.
Makes sense.
NMDA receptors, on the other hand, are involved in pain transmission and excitability. Estrogen helps keep this system balanced. It promotes the calming GABA signals and keeps the excitable NMDA signals in check.
So estrogen acts like the brake pedal for pain signals.
Without sufficient estrogen to help break the incoming pain signals from that mechanical strain of the prolapse, the nociceptive data just floods the brain.
The car alarm goes off.
The alarm goes off, the brakes are out, and the physical symptoms of the laxity feel vastly more severe than the physical dropping might actually suggest.
It's a perfect storm. The biological lack of estrogen, the structural mechanical strain of the laxity, and the neurological central sensitization all collide. The pain literally amplifies the feeling of the looseness.
It really does.
But this altered state doesn't just change how the brain processes physical pressure in the pelvis. It actually bleeds into how patients experience the world emotionally and socially.
Because pain doesn't exist in a vacuum. The thalamus, insula, and amygdala are all involved in both pain processing and emotion, so chronic pelvic pain fundamentally alters emotional regulation.
There was a really interesting study that looked at the pathway between the anterior cingulate cortex and the hippocampus, the ACC-HIPP pathway.
Yes.
They looked at this in both humans and in a rat model of chronic pelvic pain, evaluating how these subjects processed social pain, like the feeling of social exclusion or rejection.
And the findings here are deeply counterintuitive. You might expect that someone in chronic physical pain would be more fragile or more sensitive to social rejection.
Yeah, that's what I would assume.
But the study found the opposite. Women with chronic pelvic pain actually showed a higher physical pain threshold during situations of social exclusion.
Wait, hold on. If I'm in chronic physical pain, I'm usually cranky, exhausted, and highly sensitive to everything around me. Why would I suddenly be numb to social rejection? Walk me through the actual brain circuitry there, because that doesn't sound right on the surface.
It comes down to neural overlap and triage. The neural circuits that process physical pain and the circuits that process social pain, like rejection or isolation, they overlap significantly in that anterior cingulate cortex.
Okay.
When the nervous system is chronically overloaded by physical pelvic pain, it enters a state of triage. It essentially blunts or numbs the emotional processing of social exclusion because it only has so much bandwidth.
The nervous system is too busy dealing with the physical fire alarm to fully process the social one.
Yes. The experience of long-term, relentless physical pain actually leads to social pain numbing.
Because we are suddenly talking about psychology, anxiety, and social exclusion, doesn't this risk making the listener think we're going right back to saying the pain is all in their head? That it's just stress?
We must be crystal clear here. Based on all the clinical frameworks we have, this pain is absolutely, unequivocally biological and neurological. It is measurable.
But psychological stress, anxiety, and trauma share that exact same neural real estate in the brain as physical pain.
Exactly. Anxiety doesn't cause the pelvic pain. But because the nervous system is already in a state of central sensitization, that car alarm is already blaring, psychological stress can further amplify the sensitization.
It's a feedback loop.
Right. A stressful day at work doesn't invent the pain, but it absolutely pours biochemical fuel on a nervous system that is already hyperreactive.
So it's not the root cause, it's an amplifier. If the brain and the muscles have learned this maladaptive, painful loop that exacerbates the feeling of laxity, how do we fix it? We need to talk about the path forward.
The good news is that neuroplasticity, which is the brain's ability to fundamentally rewire itself, works in both directions.
Thank goodness.
If the brain can learn to be hypersensitive, it can be retrained to turn the sensitivity back down. And this requires conservative, non-surgical treatments that target both the brain and the body simultaneously.
Let's talk about targeting the brain first. There's been some fascinating research evaluating transcranial direct current stimulation, or TDCS, for chronic pelvic pain.
This is a fascinating frontier. TDCS is literally non-invasive brain stimulation. They place pads on the scalp and deliver a very mild, barely noticeable electrical current to modulate the resting membrane potential of the neurons in the brain's pain centers.
So they're altering the electrical baseline of the brain cells.
Yes. They're coaxing those hyperactive neurons to have a higher firing threshold, meaning it takes a lot more stimulus to trigger the pain alarm.
Wow.
The data show that TDCS successfully and objectively increase the pain thresholds in chronic pelvic pain patients. They are literally rewiring the brain's electrical activity to shut down the sensitization.
That is straight out of sci-fi, but it actually works.
Right.
And then we have to target the physical habits.
Yeah.
Because you can't rewire the brain if the pelvic muscles keep sending panic signals up the spinal cord.
Exactly.
And this brings us to pelvic floor physical therapy. But if Kegels are out because they just squeeze an already squeezed muscle, physical therapy must have to work in reverse. Are we talking about actively learning how to relax?
We are. If you have a hypertonic pelvic floor, remember our dry, tightly squeezed sponge doing Kegels will backfire spectacularly. You are just forcing a spasming muscle to spasm harder. Instead, physical therapy focuses on downtraining.
Teaching the muscle how to let go.
Yes, it involves deep diaphragmatic breathing. When you take a proper deep belly breath, your diaphragm moves down and your pelvic floor naturally has to stretch and lengthen to accommodate the pressure.
Oh, I see.
You're using breath mechanics to physically stretch the pelvic floor from the inside while simultaneously signaling to the autonomic nervous system that you are safe, which helps calm that car alarm.
And unlearning bad habits is a huge part of this. Like, there's a big call out in the clinical guidelines for things like hover peeing. When you go into a public restroom and hover over the toilet seat instead of sitting down.
Oh, it is one of the worst things you can do for a hypertonic pelvic floor.
Because when you hover, your glutes, your core, and your pelvic floor are all forced to engage to hold your body weight up. You are literally training your pelvic floor to stay clenched and tense while you are trying to release urine. You're teaching the muscle the exact opposite of what it's supposed to do during a biological release.
This raises an important question about how modern medicine approaches these conditions. We have to stop treating the pelvis in total isolation from the brain. We have to adopt a true biopsychosocial approach.
Yeah.
You treat the local tissue, you rewire the central nervous system, and you support the psychological toll it takes on the patient all at the same time.
So what does this all mean? Let's trace our steps. We started with the paradox of tight muscles completely mimicking weak, lax muscles because they're too exhausted and squeezed tight to absorb any pressure.
Right.
We watched the nervous system arm a hypersensitive car alarm through central sensitization, reacting to heat on a thumb before the pain even started.
Which is still wild to think about.
We discovered how dropping estrogen levels remove the brain's natural pain brakes and how the mechanical strain of a mild prolapse floods the brain with distress signals, making the feeling of laxity exponentially worse.
And we learned that this isn't in your head.
Exactly. It's a measurable biological loop that causes real physical and social numbing, but it can be unlearned through targeted neuromuscular retraining. Your pain is real. Your frustration of having clear scans is incredibly valid, and most importantly, it is highly treatable.
It is. And as we look to the future of these treatments, I'll leave you with this final thought to mull over.
Okay.
If our brains can physically rewire themselves to hyperfocus and amplify the pain of a structural issue like laxity, could researchers eventually use highly immersive virtual reality to reverse it?
Oh, wow.
Imagine a therapy where you put on a VR headset and use visual motor illusions to literally trick the brain into seeing and experiencing a perfectly functioning, pain-free pelvic floor in real time.
That's incredible.
By feeding the brain safe, positive visual data that contradicts the pain signals, we could potentially hack the central nervous system and dial that car alarm back down to zero without a single surgical incision.
Hacking the brain's visual center to heal the physical body. It just goes to show, when you step out of the clean, binary world of a normal X-ray and you embrace the complex reality of the human nervous system, the solutions become just as incredibly dynamic as the problem.